Alrighty, so it is 1 p.m. So thank you everyone who has already joined us. We have a very special presenter with us today, Dr. Lori Feldman-Winter. She will be presenting on the American Academy of Pediatrics updates for breastfeeding recommendations. And we will give the formal introduction now. And thank you, Anne.
Thanks, everybody. And I see we have people from all over the country logging in. And I'm logging in from internationally. I think we have some international participants as well. So I just want to welcome everybody and just say as a preface that this is not just any old webinar. This is Lori doing a webinar to celebrate the fact that she is the CHEER Lifetime Achievement Award winner for the past year. And I suppose it's typical that poor Lori, we ask her to work. We said, well done, Lori, can you do a lecture? But we'd really want to honor you, Lori, for your award and the fact that you've dedicated so much time to breastfeeding, your whole lifetime's career to breastfeeding, and you've been probably one of the most influential people in the country, if not the world, in this field. And we really also thank you for all the work that you've done for us at CHEER and CHAMPS and all the many of the hospitals and the people I see on who've joined have seen your presentations, met you in person. You've just been like a shining guiding light in the field. So we really, really want to thank you for that. And to honor you and thank you. And then I'll do so that and usually we do this, you know, in a conference and everyone gets to cheer in person, and in these days we haven't had so many in-person conferences, but I did want to make that special note that this is really Lori's, I don't want to say swan song because she hasn't really retired yet, but for it's a pièce de résistance for Lori, and something that we just really thrilled and honored to have her presenting. And I'll give you the sort of formal rundown on her current position and achievements. She's a professor of pediatrics at Cooper Medical School in adolescent medicine at the Department of Pediatrics at Cooper University Healthcare in Camden, New Jersey. She has a very long and eminent CV. I think in her recent past, she's the chair of the American Academy of Pediatrics section on breastfeeding. She's former chair of the Policy and Education Committees and Executive Committee for the AAP section on breastfeeding, and former member of the AAP Task Force on SIDS, an AAP representative to the US Breastfeeding Committee. She's a board member of ABM, an associate editor for the journal Breastfeeding Medicine. And some of the things that she's been doing since I have known her, she was faculty chair for the NICHQ Best Fed Beginnings Project, and he's now co-chair for NICHQ's Safe Sleep Improvement NAPS project. And she's been our dear consultant physician lead with CHAMPS and CHEER in Mississippi for ever since we've been doing that since 2014, and has also of course participated in all sorts of initiatives with and without CHEER. So thank you, Lori, from all of us, a heartfelt thank you for all the work you've done for us, for breastfeeding and everybody else. And I'll hand it over to you now, but thank you for everything.
Thank you, Anne, and thank you, Ilana. And I can't begin my part of the talk without saying thank you. I am truly appreciative and humbled by this award. I am honored and have been privileged to have worked so closely with all the folks, particularly Anne and all the folks at CHEER, CHAMPS, Cheering, which is the international group of CHEER, and really everyone that's been a part of these projects. This is what I would say is truly one of the proudest moments, second only to the little baby that you see on the right, which is my grandbaby, who is cheering along with all of us with her M shirt. The M will be the theme for the day, as you'll see as I go along with this presentation. There'll be lots of M's. So yeah, just thank you for
Well, thank you. And, you know, on a personal note, I just remember, I remember meeting Laurie. I sort of remember meeting in an elevator. I don't think we actually met in an elevator, but the first 2 times we sort of got to know each other, it was classic, Laurie. We were in an elevator in some hotel preparing for the first National Breastfeeding Awareness Campaign. And Laurie was talking about 3 people at once, one of whom was her daughter on the phone, about a dance class. And then the other one I remember is when Laurie and I were with the PDC in the meeting where they actually created the entire concept behind MPing. I just remember Laurie sort of rushing into the meeting room with like lots of suitcases. And these things have perhaps set the tone. Laurie's always doing 5 million projects at once. But we're just very, very glad to have you. So without further ado, thank you, Laurie, and please go ahead.
Okay, thanks. So first, my disclosure. I have no relevant financial disclosures. I don't intend to discuss any unapproved or investigational products. And I will be presenting today based on my own personal viewpoints. This is not meant to be a representation of the American Academy of Pediatrics, ABM, or any other institution with which I'm affiliated. So while I might say we, I mean we in the greater sense, so I'm not speaking really on behalf of any organization. What I hope to do in our short time together is delineate key changes in the AAP recommendations. And I'm going to, just to be honest, I'm going to do that right up front. Really, for the bulk of this hour, I'm going to talk about the evidence for why breastfeeding matters. And then in the context of a few cases, and the policy and technical report help you and really the collective us identify strategies to help manage breastfeeding in the setting of not only jaundice, but other common conditions. So as we often do as clinicians, we begin with cases because I think that really helps frame the work that we do and the policies that you're going to hear about. So let's talk about case 1. Which is baby Mira. Then this is a real case. These are all 3 real cases. The names have been changed to protect the innocent and to carry on with the M theme. So baby Mira is exclusively breastfed for 4 months, and her parents are worried about her growth. The baby's had 6 to 7 loose CD stools per day, has some regular reflex vomiting, what we call the happy spitters, after many but not all of feeds. The mom also had a recent GI bug and was having diarrhea, felt a little sick, but that's since resolved. The pediatrician, being a pediatrician, is worried, however, about milk protein allergy, or what we call FPIES, or food protein induced enterocolitis syndrome, and I'll come back to that in a little bit. Also worried about iron deficiency because the baby's 4 months old and hasn't been getting anything but mother's milk and vitamin D. And the pediatrician recommended that the mom wean entirely and switch to a supplemental formula with a special hydrolyzed formula. So we'll come back to that. And this is baby Mira's growth chart, which we'll delve into. The second case is baby Michael, and he's ready to go home from the hospital, but has some weight loss. His birth weight was 3290 grams, and at 48 hours of age, he's now 2960. So he's lost 10% of his birth weight. He was born by cesarean delivery. His mom's breasts are soft on day 2. He attaches well at the breast and is feeding well. We'll come back to baby Michael. And lastly, baby Max. Baby Max is also a breastfeeding baby, and he's jaundiced. His jaundice was noted on the day of discharge. His bilirubin is 13. We're going to talk about switching from the old bilitool.org to what we're now using because of a new guideline that was published just after our AAP policy recommendations. I'm not going to delve too deeply into that new guideline because that's an entirely separate talk. Yet I will refer to it because much of what we say in the AAP policy is consistent. Really, everything's consistent with the new guideline. And we're now recommending the pdtools.org, which will help any of you on the call manage hyperbilirubinemia in the setting of the exclusively breastfeeding baby. But there's some things you need to know. And there's definitely a new way to think about this problem, which is a common problem. So with that framework, in addition, the framework of the first 1,000 days, the first 1,000 days is the time frame from conception to the second year, the end of the second year of the baby's life. We think about all the reasons for everything that was considered in the AAP policy and technical report, recognizing that this is the period of time that sets the stage for the baby's entire life with regard to neurodevelopment, health, well-being, really societal health, really focuses in on this 1,000 days. And that's the purpose of the 1,000-day campaign, which is an international campaign focused on the rights of the child, and really the rights of humans in order to provide breastfeeding and appropriate nutrition and health. We know that this is the most active period of neurological development. We also know that there's programming that occurs during this period of time that well outlasts the period of breastfeeding and sets the stage for normal growth, normal metabolism, protection against long-term chronic health diseases like hypertension, obesity, and diabetes. And it also is the period of time where we're protecting the mother's health. And we're going to come back to that because the policy, even though it's a policy in the American Academy of Pediatrics, really does speak to the health and well-being of mothers, recognizing that healthy babies need healthy mothers. And so the importance of maternal health cannot be overstated. So I'm going to begin with the punchline, and that is that there are key recommendations from the American Academy of Pediatrics that says that we recommend exclusive breastfeeding for about the first 6 months with continued breastfeeding along with the introduction of nutritious complementary food for up to 2 years and beyond. And those foods should be added at around 6 months. So 2 years and beyond for continued breastfeeding, and as long as mutually desired by mother and child. So that's really the key distinction for this updated policy compared to the 2012 statement, in addition to all of the evidence that I'm going to talk about for why we make these recommendations, because much of the evidence base has been updated. There's no evidence to support adding other food or fluid before 6 months on a routine basis. And that's after extensive review and consistent with what I'll talk about in a little bit, which is the United States Department of Agricultural dietary guidelines. Also, something that we often forget, which is that all newborns should receive 400 IUs of vitamin D once a day, beginning soon after birth. And so that's for anyone who's receiving, who's exclusively breastfeeding or even not exclusively breastfeeding and not getting 600 liters, not liters, 24 ounces or so of formula a day, which most newborns and young infants are not getting. So most babies are actually needing a vitamin D supplement. And I like to frame the vitamin D supplementation kind of as a lifelong supplement, because well beyond the period of breastfeeding or formula feeding, really throughout childhood and adolescence and into adulthood, we all need vitamin D supplementation. And that's because we don't get vitamin D in the way that we used to, which was from sunlight. And so really vitamin D supplementation is a supplementation that should be thought of as a lifelong need, and that this is just how newborns are going to get their vitamin D. What's important to note is that this happens, unfortunately, only about 25% of the time. So 3/4 of Newborns are not receiving the recommendation to supplement. And in a recent publication published in Pediatrics as a quality report, this can be enhanced through a variety of quality improvement methods in the hospital. So you can do things right at the get-go in the hospital to try to improve and close that gap on giving vitamin D. And then finally, the recommendation for continued breastfeeding for 2 years and beyond is consistent with the World Health Organization and many other organizations as well. And I've included here the WHO Global Strategy, which many of you are familiar with. So why the change for up to 2 years and beyond? For the infant and child, the benefits of breastfeeding beyond a year include the protection against ulcerative colitis, Crohn's disease, type 1 diabetes, and possibly obesity. With the evidence for maternal disease, remember I said that healthy babies need healthy mothers. The maternal protections from continued breastfeeding conferred by breastfeeding beyond 1 year is even more compelling. Protections against, again, diabetes, hypertension, breast cancer, and ovarian cancer. And we understand that in the US, women who are breastfeeding beyond a year face stigma and often don't disclose their feeding practices, even to their own doctors. And so we hope that this policy helps to erase these stigma and open conversations about how beneficial continued breastfeeding can be. And in fact, in order to do this, we need policy changes. Current US policy supports breastfeeding only through the first year. And our public health agencies, such as the CDC, collect data on breastfeeding also only up to 1 year. So we don't even have reliable ways to understand US breastfeeding rates and disparities beyond the first year. I'm fortunate to be giving this talk 1 day after the White House conference and convening on hunger, nutrition, and health. And in our new US policy on hunger, nutrition, and health under Pillar 3, where making the healthy choice should be the easy choice, our US policy delineates a variety of ways where breastfeeding can be supported and protected here in the United States, primarily through policy and legislative changes. In terms of legislation, while we have yet to pass universal paid leave, even for the states that have implemented these laws, the protections don't recognize the benefits for breastfeeding beyond a year. So when women return to work, they're not afforded the same protections for milk expression and support for pumps and supplies beyond 1 year of age. And these seemingly reasonable accommodations could go a long way, not only to encourage breastfeeding beyond a year, but also for normalizing the recommendations to continue breastfeeding for up to 2 years. The policy also focuses on inclusion and equity. It highlights the importance of justice, equity, diversity, and inclusion, which is the AAP's new JEDI approach to pediatrics. And in AAP policies, we call out race as a social construct. And we acknowledge that breastfeeding is, in fact, at the intersection of racism and bias. This policy is just another implementation of this JEDI approach. We provide the data to back up the rationale for this approach, and at the same time, we recognize the limitations in collecting such data. The AP's next call to action is to develop more specific guidance on how to eliminate racial and other disparities in breastfeeding, such as what we've done with the Cheer Champs project in Mississippi by implementation of the Baby Friendly Hospital Initiative, using a community support approach. So the policy and technical report outlines why this equity approach is so important. So now let's focus on the recommendation for exclusive breastfeeding for about 6 months. And we say about 6 months because we really take into account the developmental skills of the baby, but we also acknowledge the extensive review that was conducted by the USDA in the B24 dietary guidelines. And in this extensive review, it was determined that there was no benefit to early introduction of complementary food or any other vitamins or minerals beyond vitamin D. In addition, the evidence points to a potential increased risk of overweight or obesity, particularly when solids are introduced before 4 months of age, a practice that is, in fact, all too common in the United States. In addition, despite all of the talk, and there's going to be even more chatter around this issue of allergy and early introduction of complementary foods to offset the risk of allergy. Despite this, and along with the guidelines from the European Food and Safety Authority, the majority of infants don't need complementary foods until around 6 months of age, even in the context of prevention of allergy. And those who start 6 months start complementary foods at 6 months actually end up receiving more human milk during the first 6 months than those that are offered complementary foods sooner. And that affects the overall energy intake and infant growth. The benefits to exclusive breastfeeding and all that added mother's milk versus earlier introduction of complementary food include the health outcomes of decreasing lower respiratory tract infection, decreasing severe diarrhea, ear infections, and obesity. So in that context, let's return to case 1, baby Mira, who's been exclusively breastfeeding for 4 months and whose parents are worried about growth, albeit the mid-parental height would place her at an adult height somewhere probably around 5'7", at most maybe 5'6". And so, not quite 50th percentile. And the pediatrician's recommendation to completely stop breastfeeding and wean to a hydrolysate formula. In baby Mira's case, there's no evidence of allergy, food allergy, and there's no family history of food allergy, and there's no evidence of blood in this baby stool. So let's talk a little bit more about exclusive breastfeeding and allergy. And this comes from the AAP's recommendation on the prevention of food allergies from the Committee on Nutrition. And our policy is in alignment with the Committee on Nutrition's policy on the prevention of food allergy. And they acknowledge that there's a lack of evidence to support maternal dietary restrictions, either during pregnancy or during lactation, to prevent atopic disease. A very common, unfortunately, very common recommendation that I hear from families that have been given the advice to either reduce or completely eliminate foods. Really what that ends up doing is minimizing the nutritional intake of the mother. And there's also a lack of evidence that partially or extensively hydrolyzed formula prevents atopic disease in infants and children, even in those high risk for allergic diseases. And I should call out the fact that this is a change from the 2008 report, where the AAP concluded that there was, in fact, modest evidence. So it's important that we disseminate the information, that doing exactly what this pediatrician recommended for this family is not evidence-based. Exclusive breastfeeding for the first 3 or 4 months actually decreases the cumulative incidence of eczema in the first 2 years of life, and any breastfeeding beyond 3 or 4 months is protected against wheezing in the first 2 years of life. So really our best evidence is that breastfeeding protects against allergy, not weaning to hydrolysate formula. Finally, what about this thought that baby Mira had a condition called EPIs? So we have another policy that addresses from 2019 that addresses the introduction of peanut-containing foods to reduce the risk of peanut food allergies as early as 4 to 6 months, but that's in highly allergic families. That's not in this case, and that's not in most families. The condition of food protein-induced enterocolitis syndrome, or FPIES, usually presenting in the first 2 years of life, has a very rare incidence of 1 in 7,000 children. And these babies have repeated vomiting. They're often floppy and pale and cold and have constant diarrhea. Loose CD stool 6 to 7 times a day is the normal breastfeeding stools. So FPIES in an exclusively breastfed baby is rare, and that's not what this baby had. Although I will tell you that this too is an all too common miss and overdiagnosis made. What about the suggestion that baby Mira needs to get iron, given that the baby's 4 months of age? Well, we acknowledge in the AAP policy that the AAP previously has published recommendations for supplementing with iron in infants beginning at 4 months of age for healthy term, normal, exclusively breastfed babies. Mind you, this was published in 2010. Since then, the publication, there has been data to support the fact that delayed cord clamping has been shown to increase iron stores among healthy term newborns. I like to call it appropriately timed cord clamping because I think when we call it delayed cord clamping, we somehow think that it's aberrant. But this practice of clamping the cord after at least 60 seconds, if not 90 seconds after delivery, has become commonplace among delivery hospitals. And while there is some evidence, we need to do further research to show that it's unnecessary to provide healthy term exclusively breastfeeding babies with complementary iron. In addition, the USDA B24 guidelines concluded that complementary foods as a way to introduce iron initiated earlier than 6 months offered no benefit. So again, either iron drops or even complementary foods were not needed. Supplemental iron may be needed in cases where the baby was born prematurely, had excessive blood loss, has documented anemia, or was small for gestational age. But as I said, the dietary guidelines for Americans with the B24 recommendations showed that there was moderate evidence that either introducing complementary foods at 4 months or even iron drops offered versus 6 months offered no additional benefits. So let's go through some of the evidence base and health outcomes associated with breastfeeding. So first, short-term breastfeeding benefits. This just goes through much of the protections offered primarily during the period of time that breastfeeding is happening. And that begets a thought process about mechanisms. You know, what's happening? How is breastfeeding providing this protection? There's a lot of passive protection offered through human milk to protect against ear infections, severe diarrhea, lower respiratory tract infections, and even sudden infant death syndrome. But there's a lot of other factors in human milk and through the process of direct breastfeeding that establishes a healthy immune system and a healthy microbiome that offers these protections that are not so easily conferred by passive immunity. The long-term benefits of breastfeeding are protections that are offered well beyond the period of time that breastfeeding has ceased. So things such as protection against asthma and eczema, as I talked about, the allergy guideline, In addition, the protection against Crohn's disease, ulcerative colitis, and obesity, these are some of the conditions, again, where we have evidence that continued breastfeeding beyond a year offers even more protection than shorter durations of breastfeeding. In addition, the protection against diabetes, type 1 diabetes, type 2 diabetes, and then leukemia, which is something that many people don't even know about, the fact that breastfeeding can actually protect against cancer in the child. And again, that's presumably due to changes in the way that the baby's immune system is developing and impacted by not only the properties of human milk, but even through direct breastfeeding and the establishment of the healthy microbiome. Finally, breastfeeding is associated with an increase in IQ. And while it may not seem like a lot in a meta-analysis looking at 16 studies, a 3.4 point increase, when we think about that on a population scale, it's a considerable change. Further, the protection against lower respiratory tract infections, severe diarrhea, otitis media, and obesity are the health outcomes that are specifically tied to exclusivity of breastfeeding. So the requirement that there not be anything else in the diet is related to these factors. Again, exclusive breastfeeding for 6 months. And I'm going to call attention to this one study to discuss the fact that not only does breastfeeding matter, but breastfeeding may save lives. So this is a huge national study conducted by folks at the CDC in collaboration with some academic medical centers, looking at a combined database from our birth certificate, which includes infant feeding information at the time of hospital discharge, and then connects that birth certificate data to our infant mortality data and can pull out and extract babies' deaths due to sudden unexpected infant death at various time points. So in this analysis, really any breastfeeding, so just initiating breastfeeding, which is what's captured on the birth certificate, is associated with a decreased adjusted odds of overall infant deaths, so deaths from day 7 of life to the first year of life, late neonatal deaths, which are babies that are dying in that first month of life. Again, a huge reduction in the odds of death. And then in those post-neonatal deaths, so this is a period of time that captures the sudden infant death syndrome or SIDS deaths. Again, after adjustment of all the confounding variables, showing that breastfeeding matters and presumably saves lives. Much of the health outcomes that are discussed in the policy and technical report come from the evidence-based review that was published by ARC in 2018. There have since been other other isolated studies and other systematic reviews that were also included in the policy and technical report. And I'm just going to take a moment to talk about our review process. So the AAP policy and technical report began as a revision to the 2012 policy 5 years after publications around 2017. And so this process to getting the policy and then ultimately the technical report was a lengthy process that involved an extensive review. So in addition to the policy, we were asked to write a technical report to substantiate all of the evidence base, including the ARC evidence and other evidence that went into the recommendations. And those underwent internal review with just about every section and council and committee within the American Academy of Pediatrics, but also went outside of the AAP for external review to our colleagues at ACOG and other liaisons outside of the AAP, and then came back and went through several layers of leadership level review within the American Academy of Pediatrics. I would like to say that in this process of extensive review, we were not only responsive to the review process, but we were educating our colleagues along the way. And so in a way, this was our way in which we could disseminate all of this evidence on a wider scale. So now I'm going to talk about maternal benefits. As I mentioned, I think the maternal benefits for continuing to breastfeed beyond a year are even more compelling than the pediatric benefits, and they have to do with breast cancer, ovarian cancer, and also type 2 diabetes and hypertension. We also talk about the rates of breastfeeding and how close or far we are from meeting targets at the time of the writing of the policy. We had our Healthy People 2020 objectives for breastfeeding, and at that point, we could see the 4 stars here, the objectives that were actually met in 2020, and we were close to meeting the exclusive breastfeeding or increasing breastfeeding at 6 months target. We had quite a bit to go in terms of decreasing formula introduction in the first 2 days, but I should say that we met none of these targets when looking at the populations of color. We were far from meeting any of these targets, so really highlighting this issue of disparities. In addition, what we now have for 2030 are 2 Healthy People objectives, and that is exclusive breastfeeding for 6 months. So instead of having our target be 25%, we actually almost doubled that. So our target for exclusive breastfeeding for 6 months is 42.4%. And then continued breastfeeding for 12 months, which is 54%. Again, at this time in 2020, it was 34%. So we bumped up those targets considerably. And again, one point of frustration is that we can only set targets for data that we have. So we can't even set a target for breastfeeding for 2 years because we don't have data in which to measure that target. So that's really where advocacy comes in. And I think we have work to do to be able to gather the necessary data and then set the appropriate targets. We have struggled to decrease, certainly to eliminate disparities by race, ethnicity, as you can see by the purple bar, where we've been increasing breastfeeding for every one of the categories shown on this slide. We continue to have about the same level of disparity between the Black population and non-Hispanic Black population and the Asian population is captured by the CDC. And then when we look at every time point, any 6 months, 12 months, exclusive at 3 months and 6 months, you can see that the lowest breastfeeding rate in every one of the categories continues to be the non-Hispanic Black population. And what's not reflected here is the American Indian Alaska Native population, which would be similar to the non-Hispanic Black population if captured. Next, we talk about what it is that we can do to help increase breastfeeding support. And that begins after the prenatal period begins in the hospital with skin-to-skin care after delivery. We point to our clinical report, which defines safe skin-to-skin care for healthy term newborns and keeping mother and newborns together throughout the stay, which is basically step 7 of the Baby Friendly Hospital Initiative, or 10 steps of successful breastfeeding, breastfeeding on a cue-based manner, and training hospital staff. Really training hospital staff not only around breastfeeding, but really about providing culturally competent care, culturally congruent care. And I would even go beyond to say that we need to build a pipeline of diverse healthcare workers, because we know from the evidence that really what we need is a diversified workforce in order to ultimately eliminate disparities. We talk about another step, what we sometimes call the 11th step, although there could be a lot of 11th steps to the 10 steps to successful breastfeeding, and that this one is delayed bathing. So we call out specifically delayed bathing until after 12 hours of age, with the evidence that that provides more uninterrupted skin-to-skin time and improves in-hospital exclusive breastfeeding rates. And that breastfeeding should really be assessed, and in order to be assessed appropriately, the staff need to be trained, and really the training needs to happen not only for the staff nurses, but also for the physicians and advanced practice nurses that are working alongside, to really identify when breastfeeding is going well, to be able to look at breastfeeding and help to improve the latch, or help provide suggestions, knowing that the time that the mother's in the hospital predominantly is a time frame during the first stage of lactogenesis, where there's not a lot of milk production, and really where babies are just suckling and stimulating that second phase of lactogenesis. But really understanding what we're seeing when we're assessing breastfeeding, and being able to provide that anticipatory guidance is so crucial. And again, this is all summarized by the ARC report, Agency for Health-Related Research and Quality. And what is said in the AAP policy on breastfeeding is that hospital practices should be implemented that have been shown to increase breastfeeding, such as the Baby Friendly Hospital Initiative. And we acknowledge that the ARC report calls out the Baby Friendly Hospital Initiative as one of the ways in which hospitals can, in fact, increase breastfeeding initiation and duration. As we know, by implementation of the Baby Friendly Hospital Initiative, unnecessary supplementation is avoided, and in-hospital supplementation does, in fact, decrease the duration of breastfeeding. So let's talk about baby Michael for a minute. In the case of baby Michael, we need to think about the things that might, in fact, lead to a delay in lactogenesis. And in baby Michael's case, it was the fact that he was delivered by cesarean delivery. The policy cites a evidence-based review that we conducted, published in Pediatrics, that helps to delineate different factors for why a mother might have a delay in lactogenesis. So these are the kinds of things that you might want to ask about with regard to the mother, either during the prenatal period or even before becoming pregnant. So these are all the different factors that might lead to a delay in lactogenesis, that might lead to excessive weight loss. And this is the evidence, again, behind the fact that we should not be providing unnecessary in-hospital formula supplementation. This is a study that used propensity scores, which is a way to take observational research and infer causality by really controlling for all of the underpinning potentially confounding variables in terms of breastfeeding intentions and birth factors. And IHFF is in-hospital formula feeding. And if most of those factors are controlled for what was shown in this study is that in-hospital formula feeding could lead to as much as 6 times or as little as 2.5 times when additional factors were added to the propensity score. So 6 times or as much as 6 times, but really as little as 2.5 times weaning over the first year of life compared to exclusive breastfeeding. So really a huge impact just by giving unnecessary formula supplementation. So how do we know? Well, this is an algorithm from the state-of-the-art review that I referred to a couple of slides ago, that's cited in the policy, where we have to identify the maternal risk factors for either delayed lactogenesis or low milk production, the infant risk factors, and then what are the signs that the baby has suboptimal intake. And if the baby does have suboptimal intake, what we do about it in terms of either expressing mother's own milk, which would be preferred, and protecting the mother's milk supply, because that's really a consideration that is often missed and really important, that we not only recognize suboptimal intake, feed the baby, but also protect mother's supply. The other thing that we use now are the new curves, again, something else that's cited in our policy. And these allow us to be able to monitor weight loss. And it differs depending on whether the baby was born vaginally or by cesarean delivery. And really, as I said, protect mom's supply, understand where the baby falls on the new curve, don't provide supplementation, certainly not with anything other than mother's own milk, if it's not necessary, and arranging follow-up. And again, looking at breastfeeding and looking at the latch and suckling. Vitamin D supplementation, as I mentioned, is critical, often overlooked. It is possible to give this supplement by the mom taking 64 IU per day, shown to be safe and effective, although it's important to take maternal history to make sure it's okay for her to take this much. When complementary foods are provided, they should be rich in iron and zinc. Those are the two essential nutrients that really need to be added beginning at 6 months. And just understand that breast milk continues to be a major component of the infant's diet, and will again continue to protect against diseases. We have a little bit of advice on the low birth weight in preterm baby, although there's an entirely separate clinical report on the very low birth weight baby and breastfeeding. We just provide the rationale for the importance of breastfeeding or the provision of human milk, particularly mother's own milk in the setting of premature babies. And then lastly, baby Max, who's jaundice. So baby Max is exclusively breastfeeding, could potentially have suboptimal intake, and we have to be able to recognize that. In the old bilirubin guidelines, so as I mentioned, the new hyperbili guidelines were published within weeks of our breastfeeding policy. And in both, we state that while breastfeeding, exclusive breastfeeding, used to be considered a risk factor for hyperbilirubinemia, we now recognize that while exclusive breastfeeding is associated with hyperbilirubinemia, it is not causal. Really, the most likely cause of hyperbilirubinemia in the exclusively breastfed baby is suboptimal intake. So it's really kind of exclusive non-breastfeeding, or what we would like to call suboptimal intake. So breastfeeding and jaundice is normal. In fact, really being jaundiced is the sweet spot. We don't want to see too little bilirubin either, because bilirubin is in fact an antioxidant and is necessary to keep the baby healthy and free of bacteria. But when breastfeeding is not happening and there's suboptimal intake, that can be problematic. So we don't like too high or too low when it comes to jaundice. And as you can see here, this is from the new clinical practice guideline on hyperbili. I just called out in yellow highlight that the risk factor for developing clinically significant hyperbiliary, we don't just say exclusive breastfeeding, but we actually call it out as exclusive breastfeeding with suboptimal intake. And we also don't recommend just supplementing either with water or anything else or formula if the baby's able to receive mother's own milk, either directly through breastfeeding or express mother's milk. So it's important to recognize signs of adequate suckling and to be able to teach moms how to express milk if the baby's not able to suckle. We have a section also addressing safe infant sleep and refer to the updated policy, which came out really at the same time as our updated breastfeeding policy. This was an update to the 2016 statement, so there's now a 2022 AAP policy on safe infant sleep, and it's really consistent with what was in the 2016 statement, continuing to recommend open, non-judgmental conversations with families, recognizing that there's an association between bed sharing and longer duration of breastfeeding, but that the AAP does not recommend bed sharing. They recommend room sharing without bed sharing because of the same study that was cited in 2016, which is the Carpenter study that shows a 5-fold increased risk of SUID among even breastfeeding babies when there's no other risks at play. This policy also goes through the risk reduction of other factors that contribute to sudden unexpected infant death and other things that can be recommended if families are choosing to bed share, having that conversation about other ways to protect the baby, such as the mattress and removing blankets and pillows and keeping the bed away from the wall, making sure the baby's sleeping in a supine position. And definitely tobacco, which is really one of the biggest risk factors. So the AAP policy on breastfeeding and the technical report is aimed at the pediatrician, even though lots of people use the policy and technical report. So we delineate what the pediatrician can do. As I alluded to, there are often times when pediatricians are giving ill-informed advice and sometimes misinformation, misguided information, recommendations to supplement or even completely wean. And we really want to eliminate that. We want pediatricians to be knowledgeable and be the point person for providing most up-to-date evidence-based recommendations and information about breastfeeding and working in an interprofessional and collaborative fashion so that we can all protect the mother's decisions about infant feeding, particularly if she's exclusively breastfeeding, and also that we can advocate for policies that address racism and the inequities in the delivery of care. The good news is that we've gotten a lot of positive feedback on this policy. We had messages that were posted directly to us, as well as those published in the New York Times. And we realized that breastfeeding beyond a year has been fraught with stigma, and that our policy was really welcoming to families that have made the decision to continue to breastfeed. And so in general, folks were really happy to see that we were making these recommendations and providing updated evidence. There's a variety of resources that I've included in this webinar to get additional information, and I left plenty of time for questions. So this is my typical question and answer slide, but I couldn't help myself. This is my picture of baby Maya, who's my grandbaby just yesterday.
Hey. Thank you for the pictures. All the grandparent era. So we do have, okay, and please do all post. I will send all the copies of the chat at Laurie after, so please all post your comments about that. Thank you, Alice Cheney, about how wonderful the granddaughter looks. It'll be a nice way to honor the rest of the presentation. Laurie, we did have a few questions, and I don't know if you've had. So a few people asked about vitamin D. I think you actually did address that if they're taking a certain amount of vitamin D as a mother, this may or may not impact the content of the milk. And also a couple of people asked in the chat whether, you know, there was a recommended level. Could you just address that in a little bit more detail? The specific question here is if the mother takes 6,000 units plus of vitamin D and is exclusive breastfeeding, is the baby still needing to be supplemented?
Yeah, so Carol Wagner has done those studies and has shown in the RCT that if the mother takes 6,400 international units of vitamin D, that is sufficient to produce a level in the baby where the baby does not need to be supplemented. I will tell you completely anecdotally, based on my personal experience, that giving what is now available in vitamin D drops is not hard to do, even in an exclusively breastfed baby. So it's one drop and once a day, and it gives everything the baby needs to get. And it is problematic if that's not given. So not having a sufficient level of vitamin D can lead to rickets and growth failure and immune problems, and so it's super.
And Laurie,
important.
it's available over the counter, right?
You can get it over the counter.
Question, but yeah, so distribution.
You can get it over the counter, but you have to pay for it over the counter. So if you have Medicaid, you can get a prescription so that your Medicaid will cover the vitamin D, so that you don't have to pay for it. So it's, yeah, so that's why this quality improvement project that was just published in pediatrics actually used education of families, education of the staff, and provided prescriptions so that I think when families get a prescription, they think that they need to take it. If you just say, go get vitamin D and give it once a day over the counter, it's like people are like, yeah, I can do that or not, you know?
Okay, thanks. And then another question, and I think you somewhat addressed this too, but they said, one person said that there's a notion for pediatric emergency medicine physicians that delayed cord clamping can be dangerous. And they have seen newborns in critical condition from this. Have you heard anything like this?
No. So it depends on how
delayed
delay it is, right?
Yes. So maybe if they're arriving at the ER 3 hours later.
Yeah. So some people have either advocated or actually practiced delaying the cord clamping until the end of pulsation. And I would say that could lead to polycythemia and then a problem with jaundice. And so we usually say 60 to 90 seconds is sufficient. And that's where studies are needed. More studies are needed. We have a study that was cited in the policy to warrant, the fact that maybe that's sufficient to not have to give iron drops at 4 months of age for a healthy term newborn exclusively breastfeeding baby. But I think we need more studies to show that just that 60 seconds is sufficient to give the baby enough iron stores.
We have loads of questions here, which
we're not
going to have time. So I don't know, Laurie, if you mind we can get the questions to you, and between us, we can publish them once we publish this webinar on the website. Some of them are very broad about why do they fire lactation consultants and things. But I think the medical ones, looking at the medical ones, that you're probably the person to ask. One person said, why did it take so long for the AAP to align with the WHO? That might be an interesting to answer as your final one, because we can't get into everything else.
Yeah, so it's really interesting. It really had to do with the evidence. So we started with the evidence, and the evidence really guided the process for what the policy was going to say. And it was really helpful to have the additional studies that looked at the health outcomes in the infants and children first. We didn't really have any studies that were cited in earlier statements about Crohn's disease, ulcerative colitis. We had some idea that type 1 diabetes and obesity was related, but really didn't have those other health outcomes. And then all those maternal studies had just recently been published looking at hypertension and chronic diseases. So, and more studies about breast cancer and ovarian cancer. So we really had the evidence to guide us to be able to say, the health outcomes really do differ if moms continue breastfeeding their babies beyond a year. And so there was actually, I shouldn't even say this. I mean, I can say it now because, we're in print. I used to be afraid to say anything, but we didn't get pushback on that issue. We were so afraid that we would get pushback on that issue. We got pushback on issues related to things like the Baby Friendly Hospital Initiative and the 10 steps, which have changed. And just that breastfeeding should be the normative standard, for all babies, which we know is true because we have growth standards that are used every day in clinical practice that use the exclusively breastfed baby as the normative standard. So, those things that sort of beget more broad thinking about breastfeeding as a population strategy. I think we had more people just needing to understand that and get their head around it. But the 2-year thing, it took the evidence to really get us to that point.
Quick question. How long should the vitamin D supplementation be for? How many months?
As I mentioned, it's a lifelong supplementation, right? So you're not really getting vitamin D in food when you introduce complementary food at 6 months, and around 6 months, depending on your community, you might begin to get fluoride supplementation. So instead of vitamin D only, your vitamin that you begin to get at 6 months might be a polyvifluor with fluoride if your water supply is not fluorinated. And then starting at a year, you're going to get multivitamins that should have vitamin D. If you're a child, if you're a teenager or a young adult, everybody needs vitamin D. I think that's the message I hope to have gotten across, is that it's a lifelong supplement. It doesn't end. We all need vitamin D ingested because we don't get it unless we drink a lot of milk.
We'll get a lot of sunshine, but we won't get it.
You don't get it from sunshine because of the environment, because of the ozone. So even if you sat out in the sun all the time, you don't get the same level of vitamin D as you used to get, centuries ago.
Okay, great. I think we need to wrap it up there. And we will post this presentation probably on our YouTube channel, but we will post it and we will let the mailing list know when it's posted because a few people asked that question. And we'll try to get some of the answers to some of the specific questions to you all as well. So thank you, Laurie. Thank you for showing us your lovely granddaughter. And thank you for so many people for tuning in. And I see we have people from Italy and other countries. Ricardo's on. And a lot of our participants from Mississippi. So thank you all. And thank you, Laurie. And thank you to my team for setting this up and publicizing it and getting the word out there and recording it and doing everything so smoothly. Thanks, guys. Have a good afternoon or evening or night, wherever you may be. Thank you very much, Laurie, and congratulations again on the award and all your work. Thanks.
Thank you so much.
Bye-bye, everyone. Thank you.
Bye-bye.